All right, part C of this discussion, we're going to talk about how to manage diabetes. And there's four ways of managing diabetes: diet, exercise, medication, and testing. Ideally, you need all four of those to have a fully comprehensive and effective diabetic management program. You need to control what you eat the correct foods and the correct amount of foods. You need to move more. You need medication. You need to have testing on a regular basis to make sure that what you're doing continues to work. So let's talk about insulin therapy. There are many types of insulins out there, and they all differ in four major categories. Onset, meaning how quickly do they start working. Peak, or how long it will take before they have their maximum effect. Duration, or how long they work. And the source, is it cow, pig, or human? So why do you need to know onset, peak, and duration? Why would that be at all important? Well, if you have a short-acting insulin, works very fast, it's also going to be done very fast. And you get the spikes and drops. Whereas a long-acting insulin, slow to work, but it provides help for a long time. The idea is, remember, we want to keep people's blood sugars from 70 to 100. Not very low, not very high. The other thing I want to talk about is called lipodystrophy. And that's atrophy or hypertrophy of the subcutaneous fat tissue, the fat right underneath the surface of the skin. Why do we need to worry about that? Well, you inject insulin subcutaneously or into that fat layer, and every part of the body has a different amount of fat, and that will affect how quickly the insulin is absorbed into your system. So if you're used to doing it in your belly, your body is used to the specific time of onset and peak by going there. But you want to make sure that you don't go in the same exact spot every day, or you will essentially scar that fat, that fatty tissue, and interfere with absorption. So if you're going with your arm, stay with your arm, but keep rotating around so it's not exactly the same place every day, eventually changing to your other arm or your abdomen. You want to rotate the sites around within that same general body part, because that way you'll get the same approximate absorption time. We will always administer this subcutaneously. We never give insulin orally. There are two types of insulin, regular and Novolog, that may be given IV. Before it's opened, it's best to store insulin in a refrigerator. Once it's been opened, you have 28 days at room temperature. Don't give insulin while it's cold. It's just uncomfortable for the patient. Daily doses are calculated based on weight. Usually 1/2 to 1 unit per kilogram per day is the total daily dose. Usually. Some people may need more. Some may need yet less. That's why testing is so important. We'll talk about calculating the total daily dose in class. We'll do a couple of examples. Alcohol, drinking alcohol will affect insulin and the blood glucose. So if you're using insulin, you should not be drinking alcohol. So there's four basic types of insulins. There's rapid acting, which fast onset, but it's gone quickly. There's short acting, a little slower to work, but still relatively fast. Intermediate acting, which is cloudy, and there's long acting, which is also cloudy, except Lantus. So you can't really look at the insulin and determine whether it's clear or cloudy as to what it is. You have to know. So never let somebody hand you a syringe saying, here's their insulin, go give it, because you have no idea what it is. You may be working in a place where they give you pre-mixed or pre-drawn doses. And then there's sliding scale. Sliding scale is individualized to that person. You'll be checking a blood sugar. If the blood sugar is, let's say, 150, you might give 2 units. If it's 250, you might give 8 units. And I'm just pulling those numbers at random. But that's how a sliding scale works. You check the blood sugar and you treat based on that blood sugar itself. It's also very common to have a morning dose at a specific amount every morning and then check blood sugars before each meal and at bedtime to make sure they don't need a little bit of short acting or rapid acting to cover excess sugar. There is a chart that shows the faster the onset, the shorter the duration. So we might give basal insulin, and that's what I talked about, where every day a person gets, let's say, 10 units every day. And then you might give rapid acting based on what the blood sugar shows. So that'd be basal plus. Again, you will almost never find 2 people that are on the same exact regimen. Everybody reacts differently. Everybody has a slightly different chemistry within their body. Insulin therapies. You can mix some insulin types together. You can mix the intermediate acting cloudy. You can mix the long acting cloudy. You cannot mix Lantus. Lantus is the long acting that is clear. You cannot mix Lantus with anything. If you're ordered to mix insulin, you will always mix it. You drop clear before cloudy. And we'll talk about that in class. It's easier to explain it with visuals. If Lantus is diluted or mixed with something else, the solution may become cloudy, and the pharmacokinetics and pharmacodynamic profile, in other words, absorption and onset of action, is altered, and it's unpredictable. So you cannot mix Lantus with anything. Now there's 3 ways of getting insulin in. The most common and the least expensive is the insulin vial and syringe. Very small syringe, you drop insulin by the unit. The challenge with insulin vials and syringes is if you have difficulty seeing, if you have impaired vision, or even if you have bifocals, it can be very difficult to see and get exactly the right amount of insulin. And if you've got small amounts, like let's say you're giving 4 units, well, you don't want to accidentally give 5 units because that's actually 25% too much. So insulin vials and syringes, cost effective, but technically challenging if you have poor hand-eye coordination, poor vision, if your hands shake. The insulin pens are very convenient, very simple to use. It's simply dial it to the amount you need and inject it. It's more expensive though. So that is one downside to the insulin pen. But if you have difficulty seeing, it's very easy to use these insulin pens, and you're seeing them more and more in hospitals for people that are being followed with sliding scale or even standard dose basal doses. Some people have insulin pumps. And an insulin pump is usually worn around the abdomen. It goes into a small catheter that is fed into the subcutaneous tissue. It provides continuous glucose control, non-stop, a little bit of insulin all day long, and then you can add boluses when you eat your meals. So no more needles, no extra needles. It decreases long-term complications because instead of having spikes and drops, spike and drop, you have constant coverage. So you get much better control, better compliance. It also, though, is very expensive. How about some oral medications? Oral agents work, but they do not replace insulin. Oral agents are not insulin, but they work to improve the mechanism by which insulin and glucose is produced and used by the body. For any of them to actually work, though, your patient must have some endogenous insulin. Endogenous, remember, meaning native to the inside, not exogenous. When you inject insulin, that's exogenous insulin. For somebody to use oral anti-diabetic agents, they must have endogenous insulin. Sulfonylureas have been around since the 50s. If you use sulfonylureas and drink alcohol, it may produce what's known as an antabuse effect, profound nausea, vomiting, flushing, respiratory distress, chest pain. So that's an important patient teaching. No alcohol if you're taking sulfonylureas. Second generation medications have fewer adverse effects and are more potent by weight, but they're more expensive. Primary production is to increase insulin production. So glyphosate should be taken before meals. It has the shortest onset of action, and it mimics the body's normal response to meals. So you take this right before your meal, and it helps stimulate your body's production of insulin. Melanocytes also increase insulin production. They're more rapidly absorbed and eliminated and offer a reduced potential for hypoglycemia than sulfonylureas. So if you're on sulfonylurea, you need to be very careful and watch for hypoglycemia. Biguanides came out in the mid-90s. These reduce glucose production by the liver. Remember, glucagon goes to the liver and tells the liver to make glucose. So biguanides reduce that glucose production. It also enhances insulin sensitivity at the tissue level. So it improves that glucose transport into the cells. Some people get very almost resistant to that insulin, and a biguanide breaks down that insulin resistance. But you cannot use a biguanide if a person is going for a CT scan with contrast. It will cause renal failure with contrast media. So if a person's on a biguanide, like for example metformin or glucophage, that's a very common biguanide. If they're on metformin or glucophage and they're scheduled to have a CT scan with contrast, you need to hold the metformin or glucophage for 48 hours to flush out of their system. We also have something else to go with biguanides. It does not promote weight gain. It also has beneficial effects on the plasma lipids and can actually be used to treat prediabetes. So biguanides, like that metformin and glucophage, are very beneficial and are a key reason to use. Glucosidase inhibitors also are known as starch blockers. These slow down the absorption of carbohydrates in the small intestine. These should be taken with the first bite of the meal. Medications from this class are not effective against fasting hyperglycemia. So if a person always has high blood sugar, whether they're fasting or not, this medication will not help. Thiazolidinediones. We're going to go with that. These are insulin sensitizers. They are most effective for people who have insulin resistance. They improve insulin sensitivity. They improve the transport and utilization of target tissues. They will not cause hypoglycemia when used alone. So those are a large selection of oral antidiabetics with varying levels of importance. Now, one thing though with the that last one, the insulin sensitizers, they do increase the risk of heart failure. Your patient may develop peripheral edema and have weight gain. So you'll be very careful. You will assess for peripheral edema if your person is taking thiazolidinediones. Sorry, can't pronounce it today. Peripheral edema, heart failure, and weight gain is one of the side effects of that medication. Now we also have an anti-diabetic called incretin mimetics. Incretin mimetics. These are hormones that are released by the GI tract in response to food. There's one called ezetidine. The brand name is Byetta. And Byetta enhances insulin secretion. It suppresses excessive glucagon production. So more insulin, less glucagon. It also slows gastric emptying and increases satiety and modulates appetite. So since it slows gastric emptying, your stomach is fuller longer and you end up eating less food. These are not given orally. These are small proteins that would be broken down if given orally. Amylin is for type 1 and type 2 diabetes, receiving mealtime insulin. This is sub-Q injection only. Incretin is type 2 diabetics only, may cause hypoglycemia. It's given sub-Q again. You may be able to use smaller doses of sulfonylureas with these medications. Now, there are things that can affect diabetic treatment. Illness, infection, vomiting, anorexia, stress. Let's think about why those might affect diabetic treatment. If you're ill, if you're vomiting, if you have no appetite, if you're not taking in the correct amount of food, your insulin levels could be too high. If you're taking a medicine that increases insulin production and you're not eating the right amount of food, suddenly you'll have too much insulin for not enough carbohydrates. That will pull all those sugars into your cells, causing a hypoglycemic reaction. Stress can trigger more glucagon production, which will bring your blood sugars up. So we want to make sure that we keep all of these type of factors under consideration. When a person's in the hospital, they're probably under stress. They may have an infection or being ill. They may be vomiting. They may not have an appetite. And again, something else that will affect diabetic treatment is alcohol. Most likely, your patient in the hospital is not drinking alcohol, but that's not always the case too. You may get a patient who has an alcohol order. So be aware that these may affect alcohol or diabetic treatment. Now, things that affect the blood glucose levels. Beta blockers. I mentioned beta blockers mask symptoms of hypoglycemia. It also prolongs the hypoglycemic effect of insulin, and it may cause hyperglycemia with oral hypoglycemics. So beta blockers need to be used very carefully and watch for side effects of everything. Thiazide and loop diuretics potentiate hyperglycemia by inducing potassium loss. And corticosteroids may cause hyperglycemia. If a person is taking, and we mentioned this when we're talking about asthma, if a person is taking prednisone, you'll need to watch their blood glucose very carefully because it may cause hyperglycemia. That's it for diabetes and anti-diabetic medications. Come back for the next section for the hypothalamus and pituitary gland.